All right. I hope people are enjoying the sessions thus far. This session is promoting equity through supply chain design, just to confirm that you are in the right room and not planning to attend another breakout. An interesting session. We're going to explore different aspects of using supply chain design to target equity issues. Have got a fantastic panel over here. We've got on my left, Nicole Danfakha from JSI. Nicole is a monitoring, evaluation, and learning advisor specializing in data visualization with JSI. She has over 9 years of experience creating data visualization tools, qualitative research and analysis, innovation, and implementing human-centered design practices. She is passionate about designing equitable supply chains and promote informed decision-making. And her experience ranges from malaria to family planning and reproductive to supply chain and health logistics data. She received an MPH with a concentration in social and behavior change communication and served in the Peace Corps in Senegal. A round of applause for Nicole. To her left is Emily Gibson from VillageReach. Emily Gibson is a manager on the health systems team at VillageReach with 10 years of experience in the health sector. Emily's work focuses on promoting equity and immunization access and demand by leveraging community insights to develop data-driven, innovative strategies to reach under-immunized and zero-dose populations. Prior to working at VillageReach, Emily worked as a nurse in obstetrics, primary care, and emergency services. Emily Gibson, everybody. And finally, Lisa Oot is a senior technical officer with JSI with over 15 years of experience in public health, with a focus on routine immunization. She has extensive experience in community-based approaches to increase coverage of high-impact interventions. Her expertise includes a focus on tailored problem solving to identify and reach zero-dose and under-immunized children, strategies to address and improve the immunization service experience, and practical application of behavioral interventions to improve the confidence, uptake, and acceptance of vaccination. Lisa Oot, everybody. I'll just try and run through really quick on what is the interconnection between the three different presenters here on stage right now. So Nicole here will first start by presenting an overall framework, a way to consider the pillars of achieving a gender equitable and socially inclusive supply chain. Emily would then move into more of a practical guide and what's the experience in terms of developing guidance for identifying and addressing supply chain barriers to equitable immunization coverage. Unfortunately, we had a dropout because of a visa issue. So Raj was also going to come in to present a framework for addressing issues around access, actually. So be on the lookout for a chai paper on that subject. But finally, we are ending the session with a very practical case study from Lisa on how you could improve equity and immunization access points through a case in Ghana. So with that, let me hand it over to Nicole.
Thank you. Before I start, I have to note that gender equity and social inclusion challenges impacting supply chains are part of larger global inequities. Our work addresses pieces of this puzzle, but in no way are we suggesting that these are solutions to patriarchy, ableism, racism, and other isms that we face in our everyday lives. So, supply chains in lower middle income countries have traditionally been organized to mirror administrative structures to reach the greatest number of patients, but this means they might not reach all patients. Promoting gender equity and social inclusion in the health supply chain requires us to center its many customers, not just our zero-dose children, but also supply chain staff, communities, and civil society. Within these groups, there are different people who have different needs. For example, people of different ages, abilities, migrants, or displaced persons that we must consider. We must recognize and embrace their differences to adapt the supply chain to better serve them. So today, I'll take you on a short journey to present 3 pathways that will help frame our efforts to achieve better equity and inclusion. First, I'd like to introduce you to Zara. Zara has traveled over 5 kilometers from her remote mountainous village to her health facility to vaccinate her 9-month-old baby. After waiting nearly 2 hours, she was sent home because she was the only baby there waiting to get vaccinated, and the health worker didn't want to open a vial since there weren't other children there. But what if Zara didn't have to wait for other babies to be present at the vaccination session for the health worker to administer the vaccine? What if supply planning for immunizations took special count of open vial wastage? What if consumption data, rather than demographic data, was used to account for wastage of immunizing each child that comes to the facility, regardless of the number waiting in the waiting room? What if Zara's story could help us achieve just supply chains by reimagining how supply chains are designed and monitored so that every single child has an opportunity to get vaccinated on time? Next, I'd like you to meet Nia. Nia has been an administrative officer in her district for 5 years. Supply chain has always been of interest to her, but when a supply chain officer position was posted, her supervisor discouraged her from applying, citing concerns for her safety in a logistics position. I think we could also probably put in an example about manufacturers given the data displayed during yesterday's plenary session. But what if Nia was encouraged to apply for that position? What if employers prioritized inclusion in their recruitment to encourage people of all races, genders, and abilities to apply? What if workplace conditions and policies were in place to protect staff, like safety policies to make the workplace safe and accessible? What if Nia's story could help us create a more equitable and inclusive supply chain workforce that encouraged female participation and included staff that represents the supply chain's diverse clientele? Lastly, I'd like to introduce you to Ken. Ken is a member of a local community comprised primarily of a minority ethnic group. He's part of the committee that monitors the delivery of vaccines at the local clinic. Unfortunately, recent deliveries did not match demand and services have been impacted. What if Ken had a clear communication channel to fix the delivery issue or to communicate that it was a challenge and demand did not get met? What if we could enable people and communities to have a voice and platform to demand high quality services from the supply chain and give them the tools and space to participate, and their voice needs to hold the system accountable? What if women's groups or organizations representing a marginalized religious or ethnic group are included in supply planning and microplanning processes? What if their insight about product preferences and barriers to access vaccinations were prioritized? These 3 stories are our 3 strategies that pave the way towards a more gender equitable and socially inclusive supply chain. We have reimagined supply chain design, an equitable workforce, and elevating customers' voices. Together, this road leads toward a supply chain that services all customers of health products and improves their health and well-being by delivering the right products in the right place, in the right way, at the right time. My 2 other colleagues will get more into the weeds of this, but just wanted to share a high-level overview of what it could take to get towards a gender equitable and socially inclusive supply chain. Thank you.
Thank you, Nicole. Hello, everyone, and thank you for joining us today. My name is Emily Gibson, and I'm excited to share a little bit about VillageReach's Supply Chain Equity Guide and how to think about designing immunization supply chains for zero-dose and under-immunized communities. So, as Nicole has also said, supply chains are often designed for various reasons, often cost efficiency, but may not consider equity to reach communities with low routine immunization coverage. We can bring an equity lens to supply chains by designing them to be responsive to the needs of under-immunized and zero-dose populations. This is relevant not just in remote and rural areas, but also for low-income communities in urban settings, populations in conflict or security compromised areas, and communities of internal and cross-country migrants. To support this process, VillageReach developed a 4-step guide to applying an equity lens in supply chains. This guide was designed to help decision makers identify and address the supply chain barriers that limit access to health products, especially immunization in underreached communities. The Supply Chain Equity Guide follows this 4-step process. Step 1 is to identify the underreached population and their characteristics. Step 2 is to consider the supply chain related challenges that might be resulting in low coverage for that population. Step 3 is to determine mitigation strategies to address the challenges. And finally, step 4 is to identify relevant metrics to evaluate progress toward reducing those supply chain inequities. And while the version of the guide I will share today is focused on supply chain specifically, we have found internally that the high-level steps of this guide are useful in many contexts, and we've adapted to use it for other types of interventions, for example, demand generation. The 4 steps of the guide are also closely aligned with Gabby's IRMMA framework, so identify with step 1 and step 2, reach with step 3, and monitor and measure in step 4. And the supply chain guide itself is an interactive document on the VillageReach website, and I will walk us through quickly the tools available in each of the 4 steps of the guide. So in step 1 of the guide, the user identifies and describes the underreached community, which includes identifying important factors such as recent outbreaks and service availability. In step 2 of the guide, the user identifies the supply chain challenges relevant to the specific population. And this section of the guide is clickable. For example, we can click on the challenge in the top right, high actual and opportunity costs for people to access immunization services. And when clicked on, each challenge leads to a page like this, which includes a list of potential strategies to mitigate the challenge. Which brings me to step 3, where the user develops mitigation strategies to address the challenges we identified in the previous step. For example, some of the mitigation strategies listed here to address the challenge of high actual and opportunity costs for people to access services, meaning long travel times, long wait times, etc., are extending service delivery hours or setting up service delivery at transit points such as bus stops and borders. In step 4, the user selects outcomes and indicators to measure progress toward improving equity for the specific challenge. On each of these pages in the guide, the indicators can be clicked on, which leads to an associated page with additional details about the indicator, how to measure them, and the evidence behind them. So what's next for VillageReach with this guide? So one thing that we're actively doing right now is updating the guide. It was created a few years ago. So updating it to include a more explicit gender lens and to ensure that we're supporting gender responsive supply chains much more intentionally through this process. So that's something that's underway right now. And we're also in the process of deploying the guide in 4 countries over the next 2 years. So to begin with, in close partnership with government, we'll be implementing the guide in 2 distinct geographical situations in DRC, Democratic Republic of Congo, and in Cote d'Ivoire. In DRC, we're deploying the guide in Mai-Ndombe province, in Oshwe and Mimia health zones, which are a rural area home to, we believe, about 32,000 zero-dose children, where many health facilities have limited or no access to telecommunication services, and some are over 300 kilometers from the nearest vaccine storage facility. And then in Cote d'Ivoire, we're deploying the guide in Adjamé Plateau Atikube district and Abidjan, an urban setting where rapid expansion, construction, and internal displacement have left some communities without convenient access to health facilities and vaccination services. So I'm really excited to see how these projects go. I think it's going to be really interesting to deploy this guide both in an urban setting and in a rural setting to have a better sense of how the deployment process plays out. And we'll be documenting our experiences and look forward to sharing these findings over the next couple of years. And that concludes my overview of the guide, but if anybody's interested in learning more, please do feel free to reach out after the session. Thank you so much.
Thanks, Emily. Okay, so I'm now going to give us a case study from work that we've done in Ghana. We also had a sister project in Nepal, so if anyone wants to visit the poster session, there is a poster on this as well. And so what I'm going to be talking about today is how can human-centered design support person-centered immunization service delivery and planning. So this presentation focuses on a collaboration with district and sub-district health leaders to use human-centered design to develop and test behaviorally informed interventions to increase COVID-19 vaccine uptake in Ghana. And specifically really thinking about how do we put the people that we're trying to reach front and center in this process. So at the time of our work, Ghana Health Service really wanted to understand why COVID-19 vaccination was so low in particular districts. And we were asked specifically to work in Ga South, which is a urban, peri-urban district outside of Accra, and really to explore how to address barriers to uptake. We decided to utilize tools from human-centered design to engage both health workers and communities to design and implement solutions that are responsive to their needs and can be able to reduce behavioral and social barriers that they're experiencing towards vaccination. So we decided to include HCD into the microplanning process. And the reason for this is really because it's an excellent entry point for this type of engagement, as it's a tool to address barriers to developing actionable solutions to reaching every community. It really is the microplan where we design our plans, right? So why should this be a top-down process? Why not have this be a bottom-up process where we're really working with communities to design interventions and strategies that really can help reach them with services. So what we did then was to design a 4-day workshop that was had 2 distinct phases. Phase 1 was with district and sub-district health teams to review the microplanning process. I think we all know it is a complex process. Our health workers do need to be reminded of how to do this, particularly if they're not used to doing it as a bottom-up process and are just given the microplan to follow. So we did have to use 2 days to really talk about the microplanning process. And we also use this as an opportunity to orient them to human-centered design tools and processes. So that was phase 1. And then the second 2 days, we invited community members to join the workshop so that we could do co-creation and identify really enablers and barriers to vaccination uptake and co-design solutions to these problems. And we also, what this also gave the health workers who had just had training around how to use human-centered design tools and approaches, an opportunity to practice using some of what they had learned specifically with communities. So outputs were, in the workshop, participants created user personas and used the Journey to Health and Immunization map, which is a really excellent tool that UNICEF has created. If you haven't seen it, we'll talk about it further. But I suggest it's the graphic there on the left. And also to map it and examine enablers and barriers on the path to vaccination. The participants prioritized challenges and interventions for actions and co-designed action plans to then implement COVID-19 vaccination services. So as part of this process, we conducted pre- and post-evaluation questionnaires, during the workshop for health workers, and post-workshop semi-structured interviews with community members, and conducted a rapid qualitative analysis of the data. So now I'm going to just dive into a bit of the perceptions from the community members about their engagement in the process. In our analysis, we wanted to examine both health worker and community perspectives. We learned from community members that the workshop helped them to better understand the importance of vaccination and the vaccination process itself. Typically, we think about exposing community member perspectives to the health workers to help build empathy on the part of the health workers, but it also goes the other way. What we were hearing from community members is that they really learned what an extensive process it was for health workers to actually go through the whole micro-planning process and reach them with vaccination. And they said it really created a sense of empathy and warm feelings towards the health workers, recognizing how much work they put in. Community members also felt that the forum was an opportunity to provide insights to health workers and allowed for both the communities and the health workers to really talk about and communicate around local barriers to uptake. We also asked the community members around their use of HCD tools, and they really liked both the user persona and the journey to health and immunization, even though that one was a little bit more difficult to use. But it really was helpful in both community members and health workers in understanding that full journey to immunization and helped center on a more equitable approach to programming. So now health worker perspectives. HCD was a new concept for health workers, and they responded very favorably to the approach, citing that they could use HCD for microplanning for routine immunization, which is actually happening right now in Ghana, and also for other challenges beyond immunization. Health workers saw the value in incorporating HCD into the microplanning process, discussing a number of ways the process helped improve their planning and implementation of services. So I won't go through this whole slide, but there were a lot of different ways you can see from the various bubbles that health workers really felt like it contributed to improved planning and then later implementation as well. We learned that health workers can use HCD tools on their own and for future microplanning. And we also learned that health workers felt that it was feasible to use and implement, really identifying just some few barriers to use. The biggest one being the financial constraint. And we talked at length with Ghana Health Services about this and how could we really expand use of human-centered design tools and approaches and build that into pre-service curriculum, ongoing discussion. And then health workers really liked it, and they recommended that they wanted to continue using it for RI and other programming as well. This is a super quick snapshot from the pre and post test questionnaires for health workers. Post-workshop, 100% of participants felt comfortable using HCD in the microplanning process. Also, a sizable number of participants felt incorporating HCD into microplanning would result in vaccination activities that are different from those that would have been designed without using HCD. And I think that's really important, that they really did listen and use community perspectives to help shape and inform the way that they designed programs. Part of the workshop included co-designing action plans to strengthen COVID-19 uptake. And so each of the health facilities developed their own tailored plans to implement over the next many weeks, so that they implemented them over 8 weeks. During that time period, Ghana launched a national COVID-19 vaccination campaign, and the Ga South District achieved 96.2% coverage of their target population, which was a huge increase from where they were several months ago at baseline at 36%. Can we attribute this coverage directly to this programming? No, but certainly it did contribute. We conducted follow-up visits with the health workers after implementation of their action plans to examine how the entire process went. Most participants stated implementation went very well and they had continued their engagement with the community members even post the workshop, and they were critical members of the actual implementation team. The health worker felt the community engagement improves the strategic design of their planning and implementation of the approach. They discussed improved communication with communities and easier access to communities who had previously been missed. Overall, health workers and communities feel it's feasible, acceptable, and valuable to incorporate human-centered design into microplanning, as it leads to better design and implementation of immunization services. And the workshop built relationships with communities and strengthened both health workers' skills and processes to improve service delivery. That's it. Thank you.
We have 2 volunteers at the back there. If you want to ask questions, please raise your hand and they will get the mics over to you as quickly as they can. Yep, it's for the lady here.
I want you to fall down. Muchas gracias. Thank you very much for the excellent presentations. I think that the human-centered design is something that is quite new, I would say, at country level, and it has been pushed by Gavi, UNICEF, all the colleagues, and I think it's a good point. As you are mentioning here, human-centered design for, redesigning health services or co-designing health services with the community is great. I was just wondering if you already had an experience of using HCD for increasing community engagement and, increasing demand generation. I think we need also to learn from that. I don't know to which extent it's possible. Then a question for the guide. What is the name? I don't know. I wrote it. What is the name yet? The equity supply chain guide. Sorry, my memory. My brain is a little frozen today. Sorry for that. I think it's super, super interesting, and I was not aware. So I think it's a good point. I'm happy to be at TechNet to learn more about innovation and new guidance. To which extent is possible to have to facilitate actually the use of such guide with I would not say maybe digital things, but something like we are facing some bottleneck challenges regarding the supply chain. We have common challenges. So if we input something like this in maybe an app, a simple app, and maybe you have the possibility to access to different maybe root cause analysis approaches, and then some possible solutions, matrix, whatever. I think everything is in the guidance, but maybe at country level, it's more complicated for the Minister of Health, the staff, the managers, to really apply and to go into the, the content of a guideline. So I was just wondering if you envision, digitalization of such guidelines to make it something like much more like a decision-making tool, not only a technical tool, but also a mechanism for them to decide based on their problems, actually. Thank you. Sorry for you. I came a little late. I really enjoyed your presentation style with the images and the illustration. Congratulations, but I cannot ask you any question. Thank you very much.
Lisa first and then
Yeah,
Emily.
sure, I'll go ahead. Great questions. So yes, both here, we've been using the HCD process and tools and approaches to really focus on strengthening community engagement and demand. And what I didn't have time to really elaborate on here is that they co-developed. They looked at what are our biggest barriers, including community engagement and barriers related to demand along their journey to health and immunization, and they prioritized collectively what they wanted to focus on, and then they designed really very direct actions that they would take in order to address those barriers. And many of them included, so each health facility did about 4 to 6 activities that they wanted to implement. And many of them were focused both on using those community members as community champions and really trying to mobilize community engagement. But there were others that were really focused on addressing, for example, specific concerns and feelings within the communities that they had about adverse events following immunization, concerns that they had around rumors and misinformation around COVID vaccination. So there were specific strategies that were employed there. Absolutely, it can and should be used both for, I think, community mobilization. And the great thing is that when you co-design with the community, you've already made contact with these communities, and they can be your further champions. What happened was, as they were implementing action plans, the community members would come back to the health facility and say, "How are we doing on those action plans? Can I see how we're going?" And then the health workers would say, "Well, you were supposed to help me with this community mobilization. Can we go do that?" So it was really good that it really strengthened the relationship between communities and health workers. Over to you.
Thanks, Lisa. Thank you for your question. It's a great question. So the question was around if we've considered digitalizing this into an app or something that could be a little bit easier to use. And I think one of the things that we're trying to understand as we're deploying the guide is sort of how it's used by different people in different ways. So right now we're working with our country offices and with folks from EPI in partnership to deploy it. And I think my hope also is that at some point it can be digitalized. I think we're still refining it. We're still adding this gender component, as I was saying, and I envision also potentially at some point there may be a demand generation side to this as well. I think something that we often see when we're doing this type of work is everything sort of is in a continuum, and we may identify some supply chain barriers and we may also identify some demand barriers. And I think it would be great to have this guide built out in a way that it can really comprehensively address both. So there's a sort of a lot we have in store, but I would love it to be digitalized, and I think putting it into some kind of application that's a little bit more easier to interact with and feels a little bit less technical maybe is a great idea. So thank you, and I'll definitely consider that as we're moving forward.
Yep, there's the question there.
My name is Ridwan. I'm from UNICEF Pro. Just following up the question on the guidance, to what level the guidance will be fit? Is it at the community level or service delivery level, or are you aiming also at the national level? Because I think supply chain design is like very a trending topic for everyone to please design your supplier, but we need to also, I want to see the practice of that, whether how we could use this guidance to be, useful for the country. Thank you.
Absolutely, great question. So we are currently testing this out, deploying it at the subnational level. When we talked with EPI in Cote d'Ivoire, they actually were super interested in us doing kind of a national supply chain assessment using the guide. And we said, that's a great idea. We don't quite have the funding for that yet. So let's start with, a specific community. And then depending on sort of how that goes, it may be something that we try to do on a national scale. But right now we're starting at the subnational level. So selecting specific district or specific province that has kind of known challenges that's of interest to EPI. So we've been working with government to say, if we're going to just do this in one place, where are you most concerned about zero-dose kids? Like, where do you feel like, just from your anecdotal information or from data that you already have, there's a lot of challenges. So trying to dig in first in areas with just known equity issues. And then I think from there, we'll be looking at seeing if it makes sense to think about using it on a national scale, but we haven't done that yet. Thank you.
Guess while we're waiting for a few more questions from the audience, maybe Nicole, I can ask you a quick one. What else is needed to reach a gender equitable and socially inclusive supply chain?
Yeah, thanks, Ashwin. So the three pathways that we presented are high level on purpose. I think one of the next steps for us is to further develop this theory of change and think more critically about the sub themes within those pathways, such as policies and practices and other things like that, that will get us towards a gender equitable and socially inclusive supply chain. We need to continue the conversation. So we're actually hosting a virtual discussion. So I invite everyone to jump over onto the IAPHL page. I can share more information if you're interested. To hear from everyone who's already doing this work. There's lots of great examples out there of folks that are working towards gender equitable and socially inclusive supply chain. So just getting those examples and further fleshing out how we can get towards that goal. I think there will likely be some tools and definitions and indicators and certainly mindset shifts on how we think about, what are our goals and objectives and outcomes for what we want to achieve, not only in immunization supply chains, but all sorts of supply chains for family planning and reproductive health, malaria, and all the others as well.
Thanks, Nicole. Maybe a quick show of hands in the audience. How many are actually working on supply chains in their day-to-day work? That's quite a sizable audience. So hopefully this is relevant and does make sense. Is there something somebody actually wants to share from the audience on like what are good examples of advancing equity through your supply chain design work? Would love to hear. It doesn't need to be only people on the panel who have insights to share.
Actually, QT Dorothy is very surprisingly looking towards me, so I'm scared. So actually,
Could you please introduce yourself?
Yeah, I am Srihari. I'm a health specialist in UNICEF regional office in Middle East and North Africa, and so I'm health specialist for EPI and primary healthcare. So equity in supply chain redesign means I would say in designing of the supply chain, you can say redesign. There is nothing new to design. There are vaccine, there are people, and there is a people who need to vaccinate. So this vaccination triad, vaccine, vaccinator, and people to be vaccinated, this is there. How we need to deliver vaccine to the client or to the children or to the mother, best way, so that everybody get the vaccine. So in that context, often the solutions gaps are very evident. Like, are you reaching each child, each mother? So that is the concept of equity is to reach every child, every mother with all vaccines. Not that in one place you are reaching with full vaccine, in another place because in accessible area we are collecting few vaccines and not collecting all the vaccines because of many issues. So in that context, it's a planning issue. Starting from micro planning, now if you talk about micro planning, we need to have some fundamental information of each session, how far it is from the last cold chain point where you are storing vaccines. And then who is collecting vaccine, when he is going to deliver the vaccine, and when the session would start, and what is the client number, who are going to receive the vaccines. And these are probably the integral part of immunization program. When I was teaching students, public health students, we used to teach those the micro planning concept for reaching vaccine children. So things, the fundamentals has not changed, but because of the geography, because of the terrain, because of the situation, and because of the technology, because of the delivery devices, so it has been more advanced, and we should reach more number of children compared to 20 years back. So and why you are coming up with new terminology? Because we are not doing the fundamentals. Fundamentals is there is vaccine, vaccinator, and the children. So we need to see that how best to reach every children, every client with vaccines. Yes, thank you.
Translate a question. There was a question in French. I wanted you to translate that. I don't know if we can do that now or wait some interaction.
Why don't we take the question in French?
Okay, I think the colleague from Haiti was saying that this is good experience that is showing here the human-centered design in the supply chain issues. But how do we know that today we are in many contexts and security issues are now raising in many places? How this approach you are just proposing that can be implemented to solve the supply chain related challenges in those areas with this methodology? If you have some concrete example, if you can just elaborate on that. That was the question.
Lisa, do you want to have a shot?
You know, I'll say this. I think human-centered design, and I've worked for about a decade using quality improvement tools as well. You know, I think they can be applied to any setting. It's a set of tools that really help you to think about your specific contextual specific enablers and barriers. And so even in conflict affected situations, you can use this process and tools to help you identify what are the enablers, what are the barriers, what am I actually able to affect? Because certainly I think in conflict affected situations, there are going to be barriers that are just impossible to address. However, there may be other barriers that are within local resources, local capacity to address, and then you can prioritize working on those. So I think that these are tools that can be applied in any context. And I really encourage them to be used because I really think that when you're bringing it to these populations and having them really design both health workers and those communities living in conflict areas, you're going to really dig in and understand what are these challenges. I know we've been doing this actually in work in Moldova with Ukrainian refugees. And among other populations as well. And it's really been instrumental in understanding those specific issues and bringing those to the forefront of health workers. Similarly, in Ethiopia, when I worked, the refugee camps were outside of the health system, for example, and so they operated completely independently. And so we would do microplanning to try to reach those populations, but our health workers couldn't actually physically go in and work. So we designed training to work with those basically staff that were working at the refugee centers to do bottom-up microplanning just for those communities. So it also to say, I encourage its use in any context. Do you have anything to add, Emily?
I was just going to add that there is a component of the guide that speaks specifically to supply chain challenges for immunization in conflict settings or in settings with security challenges. So there are like a couple of pages dedicated to sort of collected evidence-based strategies in those contexts and indicators that can be applied to track progress, sort of even like given those scenarios. So there is a component of the guide that speaks to that type of setting as well.
Last question.
It's not a question, it's a
comment. Yep.
yes, experience sharing also, and maybe some ideas around equity of the supply chain, making sure that we can deliver the vaccine up to the children wherever they are. I think that the IRMA card, the process of documenting the situation of the countries in terms of settings, context. Is it rural? Is it a remote area? Is it hard to reach area? Is it a place where are we talking about nomadic people or people who are not easy to access? I would say. So the equity start from this one to really understand the context and the profile of the target population, I would say. Then we could see, at country level that the availability of the health facilities is not corresponding to the needs, of the population. So I think this is the first thing. And I guess that human-centered design is one critical point to really look at to which extent the population is capable to make the effort to bring the baby walking 3 kilometers to bring the baby to the health facility. So I think it's important. And maybe another point that is quite important is that to me, equity redesigning or designing the supply chain for equity goes with beyond the health sector. It means, for example, you mentioned, Felix, you mentioned about conflict areas. Currently, there are strategies that are very well known. You have to work with the humanitarian agencies. You have to work with the community health workers living already here. So you need to really expand or extend, I don't know what is the correct terminology, partnership with others to make sure that you can have this supply of the vaccine. Another point that is quite important is as you mentioned, the engagement of the community health workers or the communities themselves, but also maybe the private sector. Private sector is quite important. They can, in some case, they can be a confessional health facility. To which extent you embrace the overall opportunity. So we had example like this because we have been supporting countries developing their EIF application or FPP, full portfolio planning for Gavi, and it was not something obvious. And I think that human-centered design was something that could make the difference. And so that's why I think that now maybe we need to vulgarize or familiarize or equip countries, yes, about this, because maybe this is an abstract abbreviation, but maybe we may support better the countries to use this as a normative, normal tool to shape the supply chain systems correctly. Thank you.
Thank you. Maybe just to wrap this up, would like to hand it off to each of the presenters. Just 1 minute. How do you bring this down from abstract to ground level? And like, what more is left to be done? What should people walk away from this room with?
I guess I can start. So, how do I bring it down from abstract to on the ground level? I think just by thinking about practical examples of how we already are working towards a gender equitable and socially inclusive supply chains. We just heard from two great examples, nomadic populations, and even if we don't have tools, but just taking a second to ask the right questions and making sure that we are inclusive of all of our populations when we're practicing supply chain management practices, in our forecasting and our supply planning. Are we thinking about the nomadic populations? Are we thinking about migrants or anything that might happen in conflict settings to increase the population, and trying to be as inclusive in that as we can when we're doing our planning?
Thank you. I wanted to speak quickly to your comment because I really appreciated your comment about thinking about these sort of strategies at the last mile of the supply chain. And what I was sharing in my presentation today was much more on the theoretical side and talking about the guide, but this is a good opportunity for me to plug some of VillageReach's other work and some other sessions we have going on the next couple of days. So I'll be talking a little bit this afternoon about the idea of community health workers as vaccinators. So that's something that we've been really interested in as an organization, and we've been doing some research into understand countries where community health workers actually administer vaccines and if there may be implications for equity, and that community health workers are already out in the communities with people and bridging that very last mile of the supply chain in that way to reach some of the hardest reached communities. So that's one thing that we're exploring. And also your mention of the private sector, and that we've been starting to think at VillageReach about various strategies that we use as tools for equity and tools for supply chain equity. And so working with outsourced transportation, working with the private sector, using drones for delivery in very hard to reach places, things like that are other ways in that we've been thinking about really tangibly how do we bring equity into supply chains and not just talk about it. So we have a few other sessions going on this week if you're interested in learning more about our work in that area. Thank you.
And I'll just say, I think the most important thing we all have to, I'm sure this is not new for everyone, but it just costs more to provide equitable services, period. And it has to be something that's really recognized and embraced. It is going to cost more money to reach last mile children than it does the 80%, right? And you have to do advocacy, and you have to think about what are the solutions that we're going to invest in to be able to do that. And one of the solutions I really think we should be investing in is really building the skills of our health workforce at the lowest levels at service delivery to do local problem solving, to use the data, local data that they have available to them already, and build their capacity to connect with their communities to design local solutions. And I think that there's a lot that can go into really trying to scale that, and putting investment there. So just to say that. I hope that when we really think about last mile equity, that we're also thinking both about, I think with the focus on zero dose, we think a lot about urban areas, and there's high concentrations of zero dose, and it's very appealing to do work to reach those populations. But we also do have, the 5 children out in urban afar that it's going to take a huge amount of effort and work to vaccinate those children, but they're also equally important. So just to say that. Thanks.
All right. Thank you, everybody. Another round of applause for our speakers. That's it. Thank you. Yep. And